What is interstitium in the lung? Interstitium means parenchyma. Interstitium means parenchyma. So what is lung? Basically, you know, lung is the tracheobronchial tree that is branching into multiple branches, and ultimately it forms respiratory bronchioles that give rise to alveolar duct, and in one alveolar duct multiple alveoli opens. So this respiratory bronchiole, alveolar duct, alveoli, these are called respiratory zone. Respiratory zone where gas exchange occurs, and proximal to that these terminal bronchioles and these bronchus are called conducting zone. These are bringing oxygen and taking out carbon dioxide outside. That's why it is conducting gases. That's why we call it conducting zone. So interstitium is these structures, these alveoli, alveolar duct, respiratory bronchioles. So we are going to study pathology of these. That's why we call interstitial lung disease, or also we call diffuse parenchymal lung disease. Why it is called diffuse? Because it is not only located to one part of the lung, it is either located at multiple and bilaterally, so we call diffuse, and these are the parenchymal involvement, so we call it diffuse parenchymal lung disease. But previously I used to think that there is something in between these alveoli, like interstitial tissue, connective tissue, and the inflammation of those tissue is called interstitial lung disease. But it is not like that. In between alveoli there are not connective tissue. There are, along with these bronchus, pulmonary artery, pulmonary veins, lymphatics travels, and here you can see the pulmonary arterioles, capillaries are there for gas exchange, but there are no connective tissue in between that. If there is connective tissue, it is disease, because there should be no connective tissue to facilitate gas exchange between capillaries, which is one layer thick, and alveolar wall, which is one layer epithelial thick. So there should be no barrier between alveoli and capillaries. That's why there is no connective tissue in between these structures. But if the connective tissue starts to deposit, fibers, collagen fibers start to deposit, then it becomes disease. Then we call this interstitial lung disease or parenchymal lung disease. So this is one respiratory unit. One respiratory unit. This one respiratory bronchioles divides into multiple alveolar duct, and this is opening into multiple alveoli. So this is one respiratory unit. This is one respiratory unit. These are one respiratory unit. 1, 2, 3. And in between these there is one septa, that is connective tissue septa, and that you cannot see on CT scan, even on high resolution CT scan, because the diameter of this is less than 1 by 10 mm. You can imagine what is 1 mm and what is 1/10 of that. That much low diameter you can't see even on HRCT. So that's why if you see HRCT in normal healthy lung, you won't see this septa. But if you are seeing this septa, means there is some connective tissue deposited here, like collagen fibers, and that is pathological state. Or any cell deposit. Why these thickens? If there are collagen fibers start to deposit here, fibroblasts proliferated and collagen fibers are deposited. Or if there is cellular infiltrates, either some malignant cells, like here malignancy has arisen and this is traveling through this route and this has come here. So malignant cells, or there is any infections or any inflammation, either autoimmune mediated inflammation, so their cells has come in this area, and due to that you can see. Or either there is fluid in this part, so either cell or fluid or either collagen fibers. If these starts to deposit here, then you will see these septa in CT scan. but in normal you won't see. So we will discuss this later. So in ILD, how can disease occur? So to manifest disease, there should be some insult. So that insult might come through this route, because the route is this, or either through this route, because pulmonary capillaries are in contact with these alveoli. So something might leak from these capillaries and might incite inflammation here. So through this route, what can enter? Either a smoke, fumes, or for farmers there can be hay exposure, molds, or if you give radiation in case of lymphoma. So if you give radiation to the chest for lymphoma, that can also elicit inflammation in the parenchyma. And through this route, what can enter? And other I have mentioned, forgot, asbestos, silicosis, this can also enter here. And from this route, what can come? Drugs like methotrexate, bleomycin, amiodarone. These drugs molecules can come here, and molecules might leak here and might elicit inflammation here, fibrosis here. Or in connective tissue disease like systemic sclerosis, fibroblasts migrate here and proliferate, lay down collagens. In SLE, inflammatory cells migrate here and elicits inflammation. In rheumatoid arthritis also inflammation, fibrosis occurs. Or in capillaritis, in ANCA vasculitis, what happens that capillaritis can occur. Or in anti-GBM disease, due to this capillaritis, inflammatory cells leaks here and can elicit inflammation. In sarcoidosis, there can be granulomatous inflammation in this part of the lung. And apart from that, infection can also elicit inflammation. How? So let's suppose there is endobronchial TB here, and this endobronchial TB has started migrating here like this through this route. So endobronchial spread of TB also can cause. And endobronchial spread of mucinous adenocarcinoma. Let's suppose there is mucinous adenocarcinoma here, and this is spreading like that. So that can also mimic like interstitial lung disease when you see on CT scan. So these days we don't do surgical lung biopsy to diagnose what is the pattern of interstitial lung disease. We do diagnosis with HRCT. So we should understand what are some of the patterns seen in HRCT, because we have to give some anti-inflammatory drugs, antifibrotics. So we need to understand which pathology looks like what. Like there is UIP pattern, NSIP pattern, organizing pneumonia pattern. But to understand those, we have to understand some of the basic terms first. Like what is ground glass opacity, what is consolidation, what is mosaic perfusion, what is reticulation, what is honeycombing, what is nodules. Because in CT, in interstitial lung disease, you will see these things in CT scan. So let's talk one by one. So let's first of all talk what is ground glass opacity, consolidation first of all. So ground glass, as the name implies, it is not completely opaque, neither completely transparent. So it is opaque like ground glass that we fit in bathrooms. But consolidation is more opaque than this ground glass opacity. Here there is air bronchogram. but you don't see pulmonary vessels here in consolidation. But here you can see pulmonary arterioles, capillaries. Here you see pulmonary vessels. So to understand that, let's assume these are the alveoli, let's suppose, and these are the capillaries that are traveling through this for gas exchange. And let's suppose there is alveolar edema due to leakage of fluid from these capillaries, either due to cardiogenic or non-cardiogenic ARDS, or any infections has entered through alveoli through the tracheobronchial route and come here. So when any infection comes here, what happens that the neutrophils, monocytes start migrating into the alveoli to mount immune response, and that elicits inflammation. Proteinaceous material start depositing in alveoli, or if fluid leaks from the alveoli, from the capillaries, then this fluid starts filling in the alveoli. So when there is fluid filled in the alveoli and when you pass the X-ray beam, the X-ray beams get attenuated. When it is healthy alveoli, there is air inside it but no fluid, what happens that the beam passes through it, but here it gets attenuated, the intensity of beam gets decreased, and you see the ground glass like opacity. But here you can appreciate pulmonary vessels. Here you can appreciate pulmonary vessels as whitish. But here what happens, in consolidation, what happens that there is intense inflammation that leads to even to obliteration of these pulmonary capillaries. So you want to be able to appreciate capillaries, vessels in the consolidation. But what we will see instead, so everything becomes white, and in white you will sometimes see, let's suppose this has become white, this part. So here you can see like this or this. So these are air bronchograms. So some bronchus are oriented longitudinally, some are seen as cross sections. So it is cross section. This is in longitudinally. So since air bronchus contains air, that's why it looks black like this in the opaque background. And what is mosaic perfusion? So as the name implies, it is mosaic means variegated. What is the English meaning of mosaic? Multiple. Like I have mosaic color of markers. So mosaic, different. So variegated perfusion. Variegated. So what is the variegated perfusion? To understand that, let's suppose this is the CT scan of the chest, and these are the lung fields, let's suppose, and this is the mediastinum. So you know there are alveoli capillaries in the lung. So let's assume there is capillaritis due to ANCA vasculitis. So due to capillaritis, what happens that perfusion decreases in this part of the some parts. So when perfusion decreases in some part of the lung automatically diverts blood to other parts of the lung. So here there is decreased perfusion. Let's suppose here is decreased perfusion, here is decreased perfusion. So due to decreased perfusion, normally what you see, if there are blood vessels, you see white. But when there is no blood vessels, obliterated blood vessels, you will only see air here. So you will see air hyperlucency. So hyperlucency will occur. But here these are normal. So somewhere you will see hyperlucency, somewhere it is normal. So it gives variegated or mosaic pattern. That's why we call mosaic perfusion, because here perfusion is low, here perfusion is high, here perfusion is normal. So this is variegated perfusion. So it occurs in ANCA vasculitis also, and also occurs in hypersensitivity pneumonitis. So it can be due to problem in the capillaries as well, or can be problem in the alveoli as well. So let's suppose this is the alveoli capillaries, and in hypersensitivity pneumonitis, what happens that there is inflammation of the respiratory bronchioles. So when there is inflammation of those bronchioles, then there is air trapping during expiration. While expiration, those respiratory bronchioles constrict, and due to that air traps, and due to that you can see hyperlucency due to air trapping. So somewhere you see hyperlucency here also, and here also you see hyperlucency. So how to distinguish whether this is due to airway disease or capillaries? For that you have to do expiratory film. So you tell patient to do expiration while taking CT scan, and while expiration, if you see hyperlucency, then it means that air is trapped. But when that disappears or it assumes the normal, it means the problem is in the capillaries. Because what happens that here you will be able to expire it because there is no air trapping. So that hyperlucency will be gone. But here hyperlucency will persist. So this is about ground glass opacity, consolidation, and mosaic perfusion. Now let's talk about reticulations and honeycombing. So what is reticulation? Reticulation means networks. Multiple reticulation means multiple networks. In CT scan, you can see like there are multiple networks. So we will compare reticulations with honeycombing. Honeycomb. So let's assume this is the CT film and these are the long fields and this is the mediastinum. So in reticulation what happens that you see multiple networks. And let's also draw here honeycomb. So this is the long field and this is the mediastinum. In honeycomb also you see like this. It is located adjacent to visceral pleura, but here it is distance about 1 centimeter away from the visceral pleura. And what is basically difference between reticulations and honeycombing anatomically is that it is interlobar septal thickening and this is intralobular septal thickening. Intra and this is interlobar. Initially when I described about acinus, I had told that with each respiratory bronchioles there are multiple alveolar ducts and this one unit is called secondary pulmonary lobule, and in between these are fine septa that you cannot visualize in a healthy person. But when there is fibrosis, when the collagen starts to deposit in between these lobules, then you start to appreciate it. So this is the septa between these lobules, secondary pulmonary lobules. That's why reticulation starts to form. So in between these, if you zoom this, let's zoom this. So let's suppose these are the reticulations. So in between these, the alveoli are functioning. So they are able to do gas exchange properly. But these septal have fibrosed due to some collagen fibers or either due to some inflammation, some cellular infiltrates has here arranged, or maybe malignant cells or maybe inflammatory cells, or due to edema like in ARDS or cardiogenic pulmonary edema there is fluid and that is giving opaqueness here. But inside these alveoli they are able to do gas exchange. That's why we call interlobar. So in between lobes these septal are thickened. But here what happens that in the honeycombing these all alveoli gets damaged due to fibrosis. All alveoli gets damaged and these alveoli, alveolar ducts all merges and starts forming these honeycombings. So you know that these respiratory bronchioles, alveolar ducts and these multiple alveoli are there. So all have fibrosed and all have merged here. So it is more severe because here the alveoli are able to do gas exchange, but here alveoli, alveolar ducts all are fibrosed. So this is more severe and has rapid progression, worse prognosis compared to reticulations. And reticulations generally we see 1 centimeter further from visceral pleura, but honeycombing is adjacent to visceral pleura, and these you generally see in basal part of the lung and posterior part of the lung. Why? Because you know that our lung is like this. So you see the lung parenchyma has apico-basal gradient. Upper part has low lung parenchyma and basal part has more lung parenchyma. And posterior part of our lung has also more lung parenchyma. That's why this basal part and posterior part are mostly affected with this diffuse parenchymal lung disease. But other parts also can be involved, but generally I am saying that we see in our clinical practice the cases of ILD. So, and why this subpleural part is more involved here in the fibrosis, in this honeycombing? Because you know centrally these airway are located, and as you go distally, alveoli are more concentrated here. Alveoli, respiratory zones are more in the periphery. So it is extensively fibrosed. So it starts conglomerating all, and you see this honeycombing. So when you see honeycombing, it means that there is fibrosis, extensive fibrosis, and it has worse prognosis. We call this UIP pattern, usual interstitial pneumonia pattern, and we call this NSIP pattern. If you see reticulations, then we call it NSIP pattern. We will discuss this later, but basically this is less severe, this is more severe. So this is the difference between reticulation and honeycombing. Now let's talk about nodules. So nodules, what is the definition of nodules? Nodules means the size is 0.5 mm to 3 cm. If the size becomes greater than 3 cm, we call that mass, lung mass. But if the size is less than 3 cm, we call nodule. So in ILD there can be nodule as well, because it is inflammatory disease, and inflammation you see in sarcoidosis there is granulomatous inflammation. In some ILDs there, due to those inflammation, nodules can form. So those nodules can form along the central lobule. I told about the anatomy. Let's suppose this is the respiratory bronchiole. These are alveolar ducts and multiple alveoli are opening. So nodules can form. If forms along this, we call it centrilobular. Centrilobular, because this is centered around this lobule. This is one lobule. Radiologists call this lobule, anatomists call it asinus, and physiologists call it respiratory unit. So same thing. Radiologists call it lobule, anatomists call it asinus, physiologists call it respiratory unit. One respiratory unit. So if it is located along this, we call it centrilobular. But if it is located along the visceral pleura, we call it subpleural nodules, like hair nodules. So this, and if it is diffusely located like miliary pattern nodules, so it can be multiple patterns. So these nodules can also occur in interstitial lung disease. That's why I mentioned about this. Now let's talk about the patterns that I told, like UIP pattern, NSIP pattern, and organizing pneumonia pattern. So UIP pattern, NSIP pattern, and organizing pneumonia pattern. Organizing pneumonia. So what is UIP pattern? I already told while I discussed about honeycombing. So let's assume these are the lung field and this is the mediastinum. So there is subpleural honeycombing. Honeycombing is fibrosis. It looks like honeycombs, so radiologists call it honeycombing. So it is basically, for us it means fibrosis. Here we have to give anti-fibrotic drugs. Here anti-inflammatory drugs like steroid, mycophenolate would not work. And due to this fibrosis, what happens that there are also bronchus, side by side in the hair. So it pulls the bronchus. Fibrosis pulls the bronchus. So when the bronchus is pulled, the bronchus looks dilated. That we call bronchiectasis. So here bronchiectasis has not occurred due to primary pathology in the bronchus, that is infection, inflammation, inflammation, infection, infection, inflammation. That is not the problem here. That is not the primary bronchiectasis. Actually, this fibrosis has pulled the bronchus and it has caused secondary bronchiectasis. In NSIP pattern, also there can be traction bronchiectasis because there is also some fibrosis. I told that there is reticulations. Reticulations is also fibrosis. Like these are like reticulations. If you see, these septal are thickened. Normally we don't see this septal thickening in healthy lung because it is so tiny that it is not visible even on HRCT. But if it is visible, then it is reticulations. So, but inside between these alveoli are functioning and doing gas exchange. Thus, only this septa has thickened. So, what happens that this is collagen. So, side by side it pulls the bronchus. So, here also you can see traction bronchiectasis. And here you can also see ground glass opacity that I discussed earlier. Ground glass opacity. Because the ground glass opacity occurs due to either fluid accumulations, inflammation in the alveoli. Okay, so here you can also see ground glass opacity, reticulation, traction bronchiectasis, and what is organizing pneumonia? Here you can see halo sign and reverse halo sign. So what is halo sign? Halo means, if you have seen photo of spiritual gurus or Hindu god and goddesses, what is that? On head you can see there is whitish like sun-like, and outside there is radiations like halos. So inside it is sun-like, which means white, and outside if it is ground glass, so partially consolidation like or partial opaque, translucent, then we call this halo sign. And if it is opposite to that, we call reverse halo sign. So it means that inside it is black and outside it is opacity like this. So it is not complete opacity, like covers about 2/3. So this is not completely opaque. This we also call atoll sign. So if you look the meaning of atoll in Google, then you will know what is atoll. Atoll is basically, in sea there are some islands. Like let's assume this is the sea and there are some islands like this. So here you see it is the opacity. This is the island. And here even there is water. And this water is communicating with the sea. But here it is opaque. So similar to that, it is black here and outside it is white. So we call it atoll, looking like atoll. So we call it atoll sign. So if you see these halo signs, reverse halo sign, it means it is organizing pneumonia pattern. Here we give steroid because it is also inflammatory conditions. Here we give steroid, cytotoxics like mycophenolate and other immunosuppressants to control inflammation. Here these drugs won't work. Here we have to give antifibrotics, drugs that kill fibroblasts like nintedanib or pirfenidone. These drugs kill fibroblast because here fibroblasts are culprit. So it has worse prognosis. These have good prognosis.